Hello, Adult Health 1 students. This is Professor Nikla. I teach two cohorts of NUR 355 in case you do not have me. I am going to be doing your recorded lectures for you this semester. I am going to tell you that as I am going through and doing these, your modules are packed full of information. Okay, so these these PowerPoints are coming out to about 100 slides or more in some cases. So I highly recommend breaking these lectures into like half-hour chunks, maybe break them into section. However you want to do it. I do not recommend you sit down and try to get through the whole thing unless you're into that type of torture. And that's your deal. That's fine if that's you. This one alone is 73 slides. It is I think there's a lot of stuff on here that's going to be a review of stuff that you had in fundamentals. So, feel free to pick and choose which sections you listen to. And all of this is out of your F.A. Davis 3rd edition 2023 text. We will be sharing with you the PowerPoints that have the notes, the speaker notes attached down at the bottom. All of that is cut and pasted from the textbook. Okay, so if there's anything that you feel like you want to read directly or need to look up and see yourself, whatever the case may be, all of that it's in your textbook. All right, so this is module 1. We are covering chapters 1 through 4. Chapter 6, chapter 13. I just realized my picture shows up down in the little corner. That's awesome because I haven't showered or anything. That's good. That's fine. That feels like nursing school. Anyway, all right. So we are going to be covering, and you can get this information in your modules. So this is all from module 1. So our major concepts are foundations of medical surgical nursing, interprofessional collaboration and care coordination, cultural considerations, ethical concepts, geriatric implications, and then just a really quick overview of cancer care. All right. So this goes along with the ticket to class that we will be sharing with you and that you can complete on your own. You should be able to complete that ticket to class with information provided in this lecture. Again, you can also find all that information in your textbook because it comes straight from your textbook. All right, so here's your objectives for you. These again are the major concepts. You can find that in the modules in Canvas. So this is module 1. All right, so foundations of medical surgical nursing. I want to point out, let me see if I can get rid of this. No, I can't. Sad. All right. I want to point out this first slide has a safety alert on it that is taken directly from your textbook. I like the way your textbook is laid out. Any of these safety alerts are something you're going to want to pay attention to, simply because, we're learning to be nurses, right? So the safety alerts tell us what we need to do in our practice to make sure we are doing the right thing by the patient. So as you're going along in your textbook, I would recommend paying attention to these safety alerts because they are something that are important to nursing practice. All right, so foundations of medical surgical nursing. So medical surgical nurses are the largest group of practicing nursing professionals. According to the Academy of Medical Surgical Nurses, which is the only professional nursing organization dedicated to med-surg nursing, the foundation of all nursing practice has its roots in med-surg nursing. The mission of the AMSN includes a commitment to quality patient care, which should be, that should be our mission anyway, right? Over the years, med-surg nursing has developed into a specialty practice area, and registered nurses who meet specific requirements are eligible for certification in this practice area through the Med-Surg Nursing Certification Board. So I kind of think we all think of like med-surg nursing, as not a specialty, like especially compared to like ICU, ED, that sort of thing. But real med-surg nursing is its own thing. And don't discount it, because you are going to get patients from across the board, all levels of acuity, all levels of care, and you're going to see a bunch of different disease processes, and then you're going to be balancing that with patient and family needs, and you have a higher ratio, like a 1 to 4 or 5 or 6, right? So 1 nurse to 4, 5 or 6 patients, and that teaches you how to organize and balance your day, right? So let's see. Competency in the management and coordination of adult med-surg patients requires a strong background in the sciences, including anatomy and physiology, chemistry, microbiology, patho, pharm. Throughout this text, there's an emphasis on correlating the rationales for nursing care of this adult patient population to the physiological and pathophysiological bases of selected disease processes. Promoting an understanding of the relationship between the physiology, pathophysiology, clinical manifestations, and management of these disorders fosters more accurate interpretation of data, enhanced critical thinking, sound clinical judgment, and better clinical decision making. So basically what I just said, you're going to see people from across the board, all acuities, different disease processes, and you are, as the nurse, expected to kind of put it all together and decide what kind of safe care this patient needs to have. So this focus on competency is particularly important because the Nursing Executive Center of the Advisory Board reported that many nursing school graduates demonstrate an academic practice gap. Acute care agencies consistently report that it continues to take longer for new registered nurses to achieve clinical competency despite increased resources used for onboarding and training. In this specific study, nursing executives described that new graduates lack the expected knowledge and competency in the following areas: knowledge of patho of patient conditions, knowledge of pharm implications of medications, decision-making based on the nursing process, and interpretation of assessment data. So this is talking about you guys. When you guys graduate and get out in the field, this is what hospitals have been identifying as opportunity areas for new grad nurses, right? So basically, patho of patient conditions. What is going on with our person? And what does that mean? What does that look like? What's expected? What's unexpected? Knowledge of pharm implications of medications. So how is this med, how does it work? And what are the side effects? What are we looking for? Decision making based on the nursing process. What kind of decisions do we make? How do we make those decisions? And then interpretation of assessment data. So that would be like labs and diagnostics. What does it mean and what do we do about it? So our safety alert box says that the 2 most common reasons that new graduate nurses are disciplined are 1, failure to notice changes in patient status, and 2, failure to act when a patient is deteriorating. So what that means, failure to notice changes in patient status. What that means is that our patient had a change in condition and we didn't pay attention to it, right? And that's one of the things we're there to do. That's why we spend 12 hours a day with hopefully the same patient load all day. Now, obviously that's not true for ED, but for most other units, that's the goal. They call that continuity of care, meaning that whoever is caring for that person is continuously caring for that person. So you do get a sense of what is the norm, or at least what the baseline was when you started your shift, right? So then if you see a change, maybe it's blood pressure, fever, level of consciousness, something like that, you can say, well, this is not what this guy was like at 8 a.m. Something has changed, right? And then number 2 is failure to act when a patient is deteriorating. So that basically means, all right, I've noticed my person is actually kind of taking a turn for the worse, going down the drain a little bit. What do I do about it? Right? We can't just ignore that. We need to do something. We need to maybe let the physician know. We need to make educated nursing choices, decisions, what we need to do about our patient. All right, this is on clinical judgment. Clinical judgment as the observed outcome of critical thinking and decision making. It is an iterative process that uses nursing knowledge to observe and assess presenting situations, identify a prioritized client concern, and generate the best possible evidence-based solutions in order to deliver safe client care. Clinical judgment is a required competency needed in the increasingly complex environment in which registered nurses practice. Clinical judgment measurement model, this is CJMM, as an approach to measure new graduate nurses' clinical judgment. This model measures clinical judgment based on the registered nurse's ability to recognize cues, analyze cues, prioritize hypotheses, generate solutions, take actions, and evaluate outcomes. So that again is talking about we need to recognize when something is going wrong with our patient and then do something about it, right? And it needs to be an appropriate action based on evidence-based practice. Equally important to the practice of med-surg nursing are competencies in the nursing process: clinical decision-making, evidence-based care, patient-centered care, quality and safety, and interprofessional practice. The nursing process includes assessment, diagnosis, planning, implementation, and evaluation, and ultimately guides patient care. The nursing process and clinical judgment guide the nurse's clinical decision-making and plays significant roles in the med-surg nurses' decision-making process with patients and families in the current healthcare environment. So it's important to know that when you are nursing, you're not just caring for the patient, you also have that family, and that family is going to a lot of times make or break your day, to be honest, and can sometimes be the most difficult part of your day. So just keep this in mind, that everything that we're doing also not just involves the patient, but involves that family as well. Evidence-based nursing practice is the foundation of professional nursing practice. Based on a problem-solving approach to healthcare delivery, nursing care practices and protocols are based on the best evidence from research studies and the expertise of clinicians. Med-surg nursing incorporates evidence-based practice principles in order to provide the highest quality and most cost-effective care to patients and families. Evidence-based care is characterized by clinical decisions that are based on the use of the best available evidence, clinical expertise, and patient preferences. So just remember when we're using evidence-based practice, not only is it research-based, right, which we want for sure. What is the research, the scientific research shown us to be the best care? But what do the experts say about this, right? What are the experts saying? And then patient preferences. We still take into consideration what the patient wants for themselves and what the family wants for themselves. Sorry, I'm looking at my hair in this little circle thing here. So we all, like it or not, we always take into consideration patient preferences. And one of the areas that we talk about that most is like Jehovah's Witness patients won't take blood products, right? So we may know that this person needs a transfusion to stay alive. But that patient preference is to not have blood products, and we need to abide by that and respect that. So patient preference always plays a role. Evidence-based practice is also measured on how the evidence is gathered and how reliably strong that source is. So this is talking about the research aspect, right? So it's evaluating levels of evidence. And the lowest level is a systemic review of randomized control studies. And then the highest level is from expert individual authorities or committees, right? And then there's everything in between. So we not only look at the research, but we look at let's see, the level, well, we'll just go with the level of research. Let's see, I don't know. I'm stuck on a word. It's okay. But that's okay. All right. Now we're going to patient-centered care. So patient-centered care is a benchmark that acute care facilities are evaluated against, and nursing care is an important component of this evaluation. Because nursing care is provided 24 hours a day in acute care settings, patients often base their evaluations of the quality of their care on interactions with nursing staff. Patient-centered care focuses on treating patients and families with dignity and respect, and engaging patients and families in decision-making about care decisions. Competencies of med-surg nurses that are closely associated with patient-centered care include effective communication skills, empathy, caring, and compassion. So notice in there that our medical knowledge is not what's coming into play, right? That actually, a lot of times, is just kind of like, I don't want to say ignored, but a little bit ignored. So then we say equally important are the clinical competency and knowledge base of the registered nurse. And so yes, this is recognized, but I would definitely tell you that more often a patient complaint is based on the fact that they didn't like the way someone talked to them. Not how knowledgeable, not the fact that you've been a nurse for 35 years, none of that, but how you talk to them. So the relevance of patient-centered care is further underscored by the hospital consumer assessment of healthcare providers and systems. So this is called HCAHPS, okay? HCAHPS are a survey that provides a standardized approach to collecting data from patients about their experiences in hospitals. The 9 essential topics included on the HCAHPS survey are listed in box 1.5 in your textbook. So HCAHPS it's a survey put out by Center for Medicare and Medicaid, which, like it or not, rules our lives in healthcare because they are responsible for patients paying for the care they receive a lot of times. So the HCAHPS survey looks at communications with nurses and doctors, responsiveness, communication about meds, discharge information, care transition. It even asks about, I ate a banana and now I'm burping. I apologize. It even looks at the cleanliness of the hospital environment, quietness of the hospital environment, overall rating of the hospital, and then asks if you would recommend the hospital, which seems so crazy because why would you be recommending a hospital? But, so HCAHPS is given when a patient is discharging, and then hospitals are actually held accountable to their HCAHPS scores. CMS can decide not to pay facilities based on their HCAHPS scores. So why this matters to us as floor nurses is because if our hospital is not making money, then we are not going to be making money, right? If our hospital is not making a profit, or it has lost financial backing on something, then we are not going to get our raises, okay? So, like it or not, we have to take into consideration all these aspects on the HCAHPS surveys to make sure that patients are filling out their HCAHPS surveys in a positive light, and then that is reported to CMS. and CMS can base paying the hospital for services on these scores, believe it or not. And then that just has a trickle down effect. So even though it may seem like something, you know, the big joke, if you do TikTok nursing apps or nursing memes or anything like that, you know, the big joke is always, you know, did you die, right? Patients are complaining that their turkey sandwich didn't arrive quickly enough. And then, you know, the nursing or healthcare responses, but did you die, right? Well, that's all well and good. But again, these HCAHPS scores, which look at communication and care transition and cleanliness and all of that, actually do matter because it's how our facility gets paid. All right. Now this is about Joint Commission. So in Arizona, you know, we have Banner, we have Dignity, Abrazo, Honor Health. Okay, they are Joint Commission accredited facilities. So we do care about Joint Commission here in Arizona. There are other accrediting bodies. Joint Commission is the largest. Joint Commission makes recommendations. They can't tell a facility that you have to do something. They make recommendations on what to do. And then if the facility wants to have a good Joint Commission visit, then the facility goes ahead and takes Joint Commission recommendations and puts those into practice. So the Joint Commission annually publishes national patient safety goals aimed at improving patient safety through goals that focus on potential problems in the healthcare setting. The 2022 goals identified the following areas to improve patient safety. So again, these are recommendations from Joint Commission. Now, if you are Joint Commission accredited, you are expected to comply with these recommendations. So national patient safety goals are the things that Joint Commission puts out, and they're like, this is what you're going to do to provide the best safe patient care you can and have a safe facility. So identifying patients correctly, improving staff communication, uses medicines safely, uses alarms safely, prevents infection, identify patient safety risks, and prevents mistakes in surgery. So accurate patient identification is required throughout the patient experience, especially during assessments, while preparing patients for procedures and surgical procedures, and during med administration. Effective staff communication is also integral to safe patient care, particularly during handoffs, such as change of shift reports, receiving patients, and transferring patients to other departments. You know, so this is our whole, you know, 2 identifiers, right? Making sure that we have the right patient every single time, even if we've identified this guy, you know, 10 times already by 9 in the morning. You always want to make sure that you are using patient identifiers. That's one of those things that the more you do it, if you just make it part of your practice, it just becomes habit. And that's like the best option, right? Just make it habit to check 2 patient identifiers every time you interact with your person. This is about SBAR. So I think we've all used SBAR in your clinical rotations this semester. You're going to be using an SBAR report. So SBAR is one approach to decreasing communication barriers and focuses on a standard way to state the situation, background, assessment, and recommendation of patient events. SBAR enhances communication with healthcare providers and nurses. And nurses often use SBAR to report changes in patient conditions. So really, SBAR, you know, it's about making sure that you have all your information when you need to hand it off. So you're not having to go back and look something up. You're not forgetting something important, right? This really comes into play. I especially like an SBAR when you have to call a physician. Some physicians, you know, it can be intimidating, especially when you're first doing it, right? And they're going to ask you questions. So the more information you can have on your SBAR report, nice and organized, clean, clear, concise, right, the better your report is going to be, and the more likely you are to not forget something important and to have already accommodated for what questions that physician or whoever you're handing off to may ask. This is the CUSE and competencies. So CUSE and competencies are an initiative designed to prepare nurses with the required knowledge, skills, and attitude to foster continuous improvement. Or quality and safety in healthcare settings. So CUSE and competencies look at patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. And notice in that definition, it talks about attitude. Now, when you are a lot of facilities, when you have to do, sometimes they'll have a skills fair and you have to show that you're still competent to put in an IV or a Foley or stuff like that. Attitude has become part of the things that we look at, basically because, again, we're looking at what your demeanor is with patients. I don't know if anybody's ever worked with somebody who walks in during the day and the first thing out of their mouth is how much they hate the job, how much they don't want to be there, they just don't even like this, that sort of thing. And that's exhausting. And it really creates, I don't love the word toxic, but it really creates a toxic environment. And when you have people who are continuously expressing how unhappy they are, it brings down the culture and the tone and the atmosphere of the whole environment itself. So now attitude is really a part of looking at not just of your practice, right? And it will play into what kind of raises you get when they go and evaluate your care. So, and attitude is one of those things that shows up on the HCAHPS too, those surveys that we talked about. So the CUSE and competencies were recommended by IOM, and it is for pre-licensure and then graduate student nurses. So this is just stuff to take into consideration, okay? Because these do apply to you guys right now as student nurses. This talks about interprofessional collaboration and communication. So the nurse participates in interprofessional rounds with the physician, advanced practice nurses, pharmacists, discharge planners, social workers, and other members of the healthcare team. Additionally, because nurses are the primary direct provider in the acute care setting, they are often the key to communication between the various healthcare members, as well as with specialists and consultants who may be episodically involved in the patient's care. So what that means is we are the ones spending the 12 hours a day with the patient, right? So we're spending the most time. So we are going to have information that all those other disciplines do not, simply because we are there with the patient. So those other disciplines are 100% going to be looking to us to kind of give updates on where that patient's at, where that patient is at. What have we noticed related to their care or their healing process, right? Especially if, always the goal is to have the same patient load all 3 days of your shift. Again, that goes back into continuity of care. So, and that puts us in the position of being like, well, on day 1, this guy didn't even know his name. And now on day 3, he's completely alert and oriented, right? So that puts us in a really unique position of seeing how this patient's care is progressing, right? So with the increased focus on interprofessional patient care teams, attention is also being given to the importance of educating future healthcare providers together. Faculty at schools of medicine, nursing, pharmacy, social work, and other healthcare professional education settings are working collaboratively, there we go, to design and implement interprofessional educational programs. So when we are caring for patients in the hospital, it's not just us, right? It's everybody. There's RTs, physical therapy, physicians, RNAs, leadership, and even EVS, which is housekeeping. All of that comes into play. Housekeeping matters because think of all the germs we have going on in a hospital environment. At my previous two hospitals, we had outbreaks of one was VRE and one was Candida auris. And a huge part of our nursing day was making sure that EVS was cleaning rooms on a daily basis appropriately and using appropriate cleaning solutions. And then on discharge, because we certainly didn't want to admit a new patient into a contaminated room, right? So we have to work with all these people to help provide safe patient care. And it's really important. And we are the go-to because, again, we are the ones spending the most time with our patients. So more about interprofessional collaboration. This occurs when two or more professionals work together to solve problems or coordinate care. The concept that the whole is more than the sum of its parts is particularly meaningful when looking at the value of IC, interprofessional collaboration. So interprofessional collaboration is a partnership between a team of health professionals and a patient in a participatory and coordinated approach to shared decision making and communication. An important component is the inclusion of the patient and family in care and transition planning. This coordinated effort is ideally done in an atmosphere of mutual respect and shared responsibility for outcomes of care. Each individual's professional training and knowledge are used to optimize the patient's health outcomes. Team members are confident in their knowledge of each other's roles and how they contribute to the patient's care, can activate the team when needed, and hold each other accountable to meet goals. The purpose is to formulate and deliver a plan of care that is goal-directed and team-focused. Goal-directed care focuses on the overall aim for each patient. Multidisciplinary rounds. So this goes on in the hospital. You are probably even going to see this during your clinical rotation this semester. So multidisciplinary rounds. The goal is to discuss each patient with all of the team members, okay? In order to develop a comprehensive plan of care for both in-hospital and transitional care. This is done in an effort to improve hospital care, reduce unnecessary hospital days, so decreasing length of stay, and prevents readmissions. So basically, the better we communicate about a patient, the more likely they are to transition either to a lower level of care or maybe back home without any further complications, right? So they don't need to come back to the hospital. When you go and when you get a new job and you orient to a new floor, part of your orientation is likely that you follow other disciplines around. And so that's done these days because of this interprofessional collaboration. It's important to know what the other teams are doing, you know, why they matter, what we need to think about, right? So you will probably follow the other disciplines just to get a feel of what their day looks like. All right, so chapter 2, this is interprofessional collaboration and care coordination, some more. So care coordination and managing patient transitions across care settings are integral parts of nursing care and an expanding role for the registered nurse. Medical surgical nursing, quality and safety competencies, and targeted knowledge, skills, and attitudes are necessary to prepare the RN to lead care management strategies and transitional care services across the care continuum. So what this is saying is just that a lot of times nurses are the ones responsible for making sure that the patient has a clean transition, right? So from the acute care level to either lower level of care, maybe discharge home, whatever. A lot of times case managers will provide this service, will take care of this aspect of patient care. And case managers are oftentimes nurses, or they may have a social work background. A lot of them will have a community health background, something like that. But this is an area you can get into as a registered nurse. So you don't, the cool thing about nursing is you don't have to stay on the floor. There's tons of options, right? And case management is one of those options. Transitions refers to the time period when the patient is moving between levels of care and care settings, such as discharging home from an acute hospitalization. The safety of the patient is at risk during these transfers because issues may arise and adverse events may occur, causing preventable hospital readmissions and increasing costs. The patient's needs may go unmet, and there is the risk for medication errors and adverse clinical events. 2/3 of post-discharge adverse events are related to medications. I can tell you from, working in the hospital and working closely with case management, a lot of times you transfer a patient and the patient, even when you're going to acute care to a lower hospital setting, your patient gets over there and you don't have your med reconciliation completed yet. Like the pharmacy has not sent over the meds yet. So you get this person who's maybe in pain because they had to transfer. Maybe they went by ambu. Maybe it was just on a gurney, but either way, it's uncomfortable. And we don't have any pain meds, or we don't know what their antibiotic schedule is. So I can tell you that meds a ton of time will get lost in the transfer process. So RN involvement in the transitions of care process, particularly for patients with complex needs, is key to ensuring the patient is prepared and ready for safe return home to a skilled nursing facility or SNF or a rehab facility. Transitional care features a comprehensive assessment of the patient's health goals and preferences, evidence-based plan of care, engagement of patients and caregivers in planning and implementing the plan of care, and then interdisciplinary communication. The transition of care process involves med rec and post-discharge follow-up visits and calls. The implementation of evidence-based practice to guide post-discharge calls is an example of how readmission rates can be lowered with care coordination. Transitional care programs are patient-centered and typically manage the transitions of patients from acute care to post-acute care settings. The goals are to avoid poor health outcomes, ensure continuity of care, and facilitate safe transitions between care settings. Unlike disease management and case management programs that are ongoing, transitional care is time limited. Emphasis is on coordinating care, facilitating patient engagement and education, addressing the cause of poor outcomes, and avoiding preventable readmissions, focusing on the 30-day time period following discharge. A meaningful transition plan will include addressing those socioeconomic factors that affect the health of the individual. So what that means is if we are discharging somebody home, we need to make sure that that is a safe environment for the person to go home to. What if we need to send our person home on oxygen, or let's say a CPAP, right? Something that requires electricity. Maybe they don't have electricity, or maybe they're not always able to pay their bills and maybe sometimes they have electricity, but don't always have electricity. Or one of the considerations in Arizona during the summer is, do they have air conditioning? Can we safely send somebody home to a home that does not have air conditioning when it's 120 degrees outside, right? So that's part of the transition of care, all right? Let's see. So there's lots of resources that we can provide and community support groups that can help people if we identify an issue. An essential component of transitional care is patient and or caregiver education. So this is something that as nurses, we're definitely responsible for. We may have to train the patient how to use that CPAP, or the family, or whoever is going to be the caregiver. And that is something that occurs while the patient is still in facility. And then different nurses train and educate the family. And then basically it is up to us to say, yes, this patient is educated well enough that they can handle this equipment at home, or you know what, that family says they can care for this patient, but we have not seen that demonstrated. We use the teach back method. So basically, you teach me now how to do this, right? Because if you understand something well enough, you should be able to teach it. So we will use a teach back method with the patient and family. But that responsibility definitely comes on us to say whether or not that is a safe plan to send that person home and that they are able to follow through on the care that they are going to need. So this is just a slide that has important strategies in managing the transition. So that's kind of all the stuff that we talked about. One of these is respecting the patient's values, preferences, and expressed needs. So, you know, as nurses, we may have opinions. We're going to have opinions on what we think this person needs to successfully care for themselves in their home environment, whatever that may be. And they may have different ideas about that. And to a certain degree, we need to respect that. If it is a safety matter, we can always take it up with the physician. We can take it up with case management. We can take it up with leadership, right? Because again, it is up to us based on our nursing knowledge to say whether or not this is a safe transition for this person. All right, so this is just talking about the nurse as care coordinator, which a lot of that we've already talked about, right? We use evidence-based practice interventions for safe patient care, quality care during transitions. We collaborate with the interprofessional team. And then part of like case management in particular is getting community resources. What services are available? What if somebody came in and they ended up with a double amputation? You know, they can't drive anymore. So what kind of transportation is available? How are they going to get to their doctor's appointments? How are they going to pick up their meds? All of that stuff we help with before the patient discharges. This is just a nice little diagram of the interprofessional care team. These are all the people that can be involved in a patient's care. And as the nurse, again, it's kind of up to us to make sure that everybody's on the same page, that we are advocating for our patient and our patient needs and wants, and making sure that everybody knows what's going on. If there's been changes, if there's been advances. If we suddenly have a family member who's like, no, I want to take care of this person at home, you know, all of those sort of things. But look at all of those people that are involved in a patient's care. It's a ton, right? That is a ton of people that need to be on the same page. Oh, I think I skipped a slide. Hold on. Maybe not. All right. This just talks about the role of the RN as a team member. So 5 rights of delegation. So right task, right circumstance, right person, right directions and communication, and right supervision and evaluation. Okay, so those are basically our responsibilities to the patient. Okay, we are making sure that all of this is done appropriately and safely. All right, chapter 3, cultural considerations. So in healthcare, an individual's belief system influences information processing, including interactions with providers and overall healthcare system. For example, food may be considered a medicine by certain individuals because food is used to restore health, whereas others may not see food and diet from such a holistic perspective. As caring professionals, nurses must develop their ability to provide culturally relevant and sensitive care, embracing a patient's belief system and preferences, ensuring that care is inclusive, just, and respectful. So we are advocating for the patient based on what the patient wants. Cultural competence in healthcare is having the knowledge, abilities, and skills to deliver care congruent with the patient's cultural beliefs and practices. The lack of skills related to cultural competence can make it difficult for nurses to communicate with patients of cultures, races, and backgrounds that are different from themselves. Therefore, knowledge of other cultures is imperative. When striving to provide culturally competent care, the nurse includes both the patient and the family in the process, thereby providing care that respects the patient's social, cultural, and linguistic needs and preferences. Cultural competence is the ability of healthcare providers and organizations to effectively deliver healthcare services and meet the social, cultural, and linguistic needs of patients. Cultural competent care means that nurses learn about each patient and tailor nursing actions to the individual patient and the patient's needs. Cultural competent care is essential to all nursing interventions. In fact, it is a professional expectation set forth by the ANA, Standards of Professional Nursing Practice, specifically Standard 9. Respectful and equitable practice explains that the registered nurse practices with cultural humility and inclusiveness, which is demonstrated in a number of ways. So this slide just has the registered nurse practice with cultural humility and inclusiveness. So this is the competencies set forth by the ANA. So if you want to take a look at those. So cultural awareness and sensitivity. So awareness is realizing that each patient sees and interprets things in their own way. And this is the first step towards becoming culturally aware. Awareness may be defined as knowledge or understanding of a subject, issue, or situation, and cultural awareness is rooted in a desire to interact with the patient in a real and authentic fashion. Cultural awareness, therefore, is the realization and recognition that personal beliefs and values affect cultural health beliefs and potentially the view of those who are different. It is a critical starting point that nurses choose not to impose personal views on others. Awareness brings humility, further introspection, and empathy, which can help the nurse develop care that respects each patient's unique needs. To fully respect the differences of individual patients, nurses must actively create an environment and tone that are inclusive and without judgment. A nurse must be culturally aware to provide care that is appropriate for each patient and respectful of each patient's beliefs. Awareness means the nurse is curious and mindful, wishing to know more, and choosing to act in a way that respects the patient's needs, not their own needs. Acknowledging and understanding the differences among patients and learning from them is the start of a nurse's cultural awareness. Sensitivity. So, in order to provide culturally competent care, nurses must demonstrate cultural sensitivity, an understanding, thoughtfulness, and kindness that leads to inclusiveness and equity. Cultural sensitivity relates to an appreciation of one's personal needs and emotions, as well as to others' cultural practices that lead to person-centered care. Sensitivity requires tact and thoughtfulness, allowing time and energy to consider the full complement of a patient's needs. So basically, we need to take into consideration our patient's culture, right? And we need to be respectful of whatever beliefs that patient has related to their cultural belief system. Really, that's it. And sometimes, we need to think where we are coming from, right? Because we may have biases that we don't even realize we have biases about. Okay, so we need to be aware of where we're coming from, and then we need to be aware of where a patient is coming from, and we need to be respectful of that. And I apologize if you can hear the dogs barking in the background. Our bug guy just arrived and the dogs are going insane. So anyway, there we go. So health disparities. So a disparity is a difference in inequity or a discrepancy that is considered as unfair. According to the Office of Disease Prevention and Health Promotion, A health disparity is a health difference that is closely linked with social, economic, or environmental disadvantages. Health disparities are real and preventable, and they exist in all age groups, cultures, races, ethnic groups, religions, and populations who are vulnerable by virtue of sexual identity. Any difference in a health outcome that is related to bias, injustice, exclusion, marginalization, and social determinants of health may be viewed as a health disparity. For example, a nurse might assume the reason a patient was unsuccessful in increasing the amount of fresh fruits and vegetables in their daily diet is simply related to the patient's choice to eat more processed foods. However, on inquiring about the patient's living situation, the nurse learns that the patient's neighborhood has only convenience stores, no grocery stores, and the patient is unemployed, limiting the amount of money they can spend on food. Both environment and financial factors contribute to the patient's health inequity. Taking time to learn about the patient affords the nurse the ability to understand what challenges the patient might be experiencing. An accurate understanding of all the challenges allows for an ability to customize interventions. Several other social factors might affect this patient or may result from biases and discriminatory behaviors of providers. For example, the nurse might assume that a patient who identifies as lesbian is not at risk for sexually transmitted disease, so does not address health promotion strategies. Or the nurse might feel that a man who identifies as gay does not deserve information concerning prostate cancer screening. Excuse me. For each patient, the degree of risk and vulnerability grows as the number of social factors increase. So here are some of the social factors affecting healthcare equity. So it can be age, disabilities, right? Economic instability, education level, gender, income inequality, limited English proficiency, limited social support, mental health conditions, race, sexuality, and social isolation. Social determinants of health. So social determinants of health, you're really going to want to take a look at this slide and understand this concept, okay? Because this is going to come up in community health. A lot of this, you know, when we're talking about transitions of care, a lot of that overlaps into community health, right? Because if we're sending somebody home, or to maybe a care facility that is a home-based facility, you know, we need to look at what's going on in that neighborhood. When we are discharging somebody maybe from the ED and we're sending them just back out into the community, you know, what are they facing in that community, right? So social determinants of health consist of a variety of circumstances and conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So social determinant of health, there's 5 key elements, all right? Economic stability, education, social and community context, health and healthcare, and then neighborhoods and built environment. All right. Now, a lot of these are kind of based, kind of a financial based, right? So, so it serves as a visual representation framework for the Healthy People 2030 population health indicators. So Healthy People is put out by IOM. I think they put it out every 10 years, and they reevaluate like what needs tend to be in communities. You know, what we need to focus on to improve the overall health of people as a whole. So these indicators show high priority issues that affect the health and well-being of all individuals, but especially those who are vulnerable, marginalized, and burdened by social factors. All right. So again, you're going to want to be familiar with what social determinants of health encompass. Um, this is another social determinants of health slide. So the care provided to the patient must acknowledge the influence of each social determinant of health element on the current health situation, as well as the role of each determinant in the patient's pathway to improved health. Failing to consider the SDOH when providing care is a barrier to providing person-centered care. So this just says we need to take these things into consideration, right? Because we, like the example said, we can't tell somebody you need more fruits and vegetables. Meanwhile, they don't have access to a grocery store. Or, you know, maybe they have a grocery store that's about a mile and a half away, but maybe their neighborhood doesn't have sidewalks. There's no safe place to walk and they don't have transportation. Or maybe it's not safe for them to walk related to, you know, outside elements like gangs or, you know, whatever the case may be, right? So this just says we need to take these things into consideration to make sure that somebody in the community can get. All right. So nurses spend a disproportionately large amount of time with patients and serve as their advocates, protectors, and trusted confidants. So again, this goes back to the fact that we're with people for 12 hours a day, right? In many instances, nurses must guide patients and families in making difficult choices, and in some cases, they must make decisions on their behalf in consultation with other members of the interdisciplinary team. These decisions are often complex and sometimes controversial. Ethical theories and principles provide a moral framework for sound decision making. In many cases, there is no apparent good decision, only a list of the best possible options, which speaks to the challenging moral complexity that often accompanies ethical decision making. Ethical principles are also guide the moral traditions, values, and behaviors of professional nursing, which are outlined in the Code of Ethics for Nurses that we use today. So the Code of Ethics, I'm pretty sure you guys talked about this in fundamentals, but the Code of Ethics for the profession is the social contract with the public concerning the moral behaviors of the members of the profession. It reflects the pact that nursing has with the public, encompassing the moral traditions, values, and trusts that the public has come to associate with nursing. The obligations that nurses have toward themselves, patients, and communities are all guided by ethical principles. There are no right or wrong behaviors identified in ethical principles, only guidelines for the moral practice of nursing. In order to practice sound ethical decision making, nurses must know and understand their own personal value systems. The value system of the nurse and the values of the organization in which the registered nurse is employed are fundamental to ethical behavior. However, these are not always compatible. You know, one of the examples of that, I don't know if anybody remembers, but Dignity Health used to be owned by Catholic Communities West or something, something like that. Anyway, Dignity broke from the Catholic healthcare system when an abortion was performed in their hospital that was saving the life of the mother, right? Well, as a Catholic hospital, part of the Catholic belief system is, you know, you don't have an abortion. So it was a big controversy. It was Catholic Healthcare West, I believe. Anyway, but so Dignity ended up breaking from the Catholic healthcare system because of that instance with the abortion. So this was where like the value of probably the physician, because he knew the mother's life was in danger, did not coincide with the values of the healthcare system, and it ended up having a huge overreaching implication, right? So these things, I mean, it's not just on a patient-to-patient basis, but it can come into play with facilities and, you know, a whole healthcare system. So, you know, this really is important to kind of think about when you are looking at jobs at at places, who owns that facility, and what are their values, and what is their mission statement, and all of that. You know, you're going to want to know, because it's going to essentially dictate your practice. So it is important to know that you are working somewhere where your code of ethics essentially aligns with that facility's code of ethics, right? Because you're going to be expected to comply with the facility's code of ethics. So this, I mean, this may seem like something we just talk about in a broad, overreaching sort of thing, but it really does, it can really come into play into your practice. Um, This just talks about the code of ethics for nurses, interpretation and application. So this is on page 43 of your book, okay? So it was too big to put on a slide, but I would highly recommend that you just take a look at it, right? What all is covered on this? And again, that's page 43. So these are your ethical principles. You are going to want to know these ethical principles. All right, know what each one means. So we have beneficence, autonomy, justice, fidelity, non-maleficence. I have non-maleficence on there twice. You're welcome. Veracity, confidentiality, privacy, and paternalism. Okay, so know what each of these are. It's going to, it definitely comes into play on your upcoming exam. So there you go. And I can tell you, people get veracity and fidelity mixed up the most. So just make sure you look at that. And then paternalism, I was not actually familiar with that. So paternalism reflects the intention to protect individuals from their own involuntary actions or choices in the name of beneficence, which may violate their right to self-determination, which is autonomy, right? Paternalistic actions are appropriate for incapacitated patients, those who wish to engage in self-harm or harm others, or when patients demand interventions that are medically futile or harmful. So that's kind of an interesting one, right? Because that's saying that we do sometimes have the right to override a patient's wishes. So that's kind of an interesting one. And that would be one that's not taken lightly, right? Because our whole world is based on trying to advocate for the patient. So, all right, this slide talks about ethical dilemmas. The complexity of today's nursing practice cannot be overstated. Nursing ethics considers situations where there are no clear right or wrong answers. What may be right for one patient may be wrong for another. As previously discussed, there are 9 provisions in the ANA's code to guide nurses, but there is no step-by-step process for solving ethical dilemmas. There is, however, a process that nurses use every day, the nursing process, that when applied to ethical decision-making can assist the nurse in making complex decisions. A dilemma can be defined as a problem with one or more alternative solutions, where each of the alternative solutions presents ethical or practicality problems, and where all solutions are equally unpleasant. That's a really important thing. All solutions are equally unpleasant, right? There's no good option sometimes. Almost all ethical dilemmas in nursing involves the right to self-determination, which is our autonomy of the patient, and relates to the patient's right to make their own decisions about treatment. This is just a box that this slide talks about ethical decision making process using essentially the nursing process. So we assess and diagnose, we plan, we're going to want to come up with 3 alternatives, we're going to implement, and we're going to evaluate, right? So that's using the nursing process to work through ethical decision making. All right, so this slide addresses potential ethical dilemmas that may come up. And I can tell you, ethical dilemmas, they do come up. This is going to be part of your life. So informed consent, do not resuscitate orders, advance directives, durable power of attorney for healthcare, withdrawal of fluid and nutrition, and pain control, right? Do not resuscitate orders, that's whether or not we do CPR on somebody, use ACLS meds to get somebody's rhythm back to normal, hopefully re-alive them, right? Advanced directives, that addresses what kind of life-saving procedures somebody may want. Do they want to be on a vent? Do they want to receive a feeding tube? Durable power of attorney for healthcare. So that identifies usually a family member, but somebody who will make decisions on a person's behalf. Withdrawal of fluids and nutrition. I want to read you what it says in the book, because I thought this was really interesting and good information. Now, if your person is having withdrawal of fluids and nutrition, it is highly likely that palliative/hospice care is on board, and they are very practiced with these conversations. But it's good for us as nurses to know what this is about, because we may have some type of feeling about it, right? We may not feel that it's the right choice. So I am gonna read you what it says in the book. So, decision to withdraw fluids and nutrition is one of the most challenging ethical dilemmas that a nurse may confront. The patient, family, and provider ultimately make this decision collaboratively. Withdrawal of fluids and nutrition is commonly referred to the healthcare agency's ethics committee for review and input. So regardless of what facility you're at, they're going to have a ethics committee. This not only consists of like physicians, nurses, healthcare team people, but a lot of times actually it'll be somebody from the community who's not involved. And so they go over the patient's chart, all the considerations, and come to a decision. This can be end-of-life decisions. This can be donation, like organ donation decisions, all sorts of things. And as nurses, we have the right to call an ethics committee if we think something needs review. That is our right to do that. We would go to the physician, leadership, whatever, and say we think that the ethics committee should review this. So, all right. So commonly withdrawal of fluids and nutrition will be reviewed by the ethics committee. The decision to withdraw fluids and nutrition is not made lightly, because it may violate the responsibility of the provider and the nurse to promote comfort. It is often difficult for the family to understand and accept withdrawal of fluids and nutrition, because feelings of guilt may arise at the misconception that their loved one is starving to death. Nurses exhibit beneficence and fidelity by explaining the rationale for withdrawing nutrition to anxious patient families and reassuring them of the comfort and benefit derived from these measures. Patients who are in the dying phase do not need fluid or nutrition in the amounts that are necessary to sustain life, and the addition or forcing of fluids or nutrition may be detrimental to the patient's comfort. The dying phase varies by individual patient and may take several days or a relatively short period. Often there is a tendency for the family to request fluids and nutrition at levels the patient had in the past. However, as the body begins to shut down, the circulation becomes slower, so the addition of extra fluid may cause increased fluid in the lungs, causing difficulty breathing, peripheral edema, ascites, or vomiting. The addition of nutrition from either enteral feedings or IV sources may cause vomiting, constipation, or bowel obstruction from the reduced gastric emptying. In addition, there is the chance of aspiration because of the reduced gag reflex. So that is a good conversation to be aware of, right? And the physical limitations of what happens when the body dies. Everything slows down. And if you are working with a family who is not medical, they simply may not know that, right? Pain control is also on here. Patients who are experiencing pain need to be shown empathy and respect and given choices for pain relief. The alternatives for pain relief should be explained, including the advantages and disadvantages, benefits and risks, and the nurse should accept the patient's decision for pain management regardless of personal beliefs. Once the patient has chosen the method of pain relief, it should be implemented and evaluated by the nurse. This evaluation includes a dialogue with the patient concerning the effectiveness of the measures and what the nurse has observed in relation to the relief of pain. So when I was reading this, one of the things that came to mind is one, patients who may have had an opioid addiction previously, who maybe do not want those opioids back in their life, right? And so even though we know the benefits of opioids in acute care pain relief, that person may just want Tylenol or something like that. And we may have to watch them grimace as they turn and, grimace when they move and all of that stuff. And also medical marijuana, right? Marijuana as a pain relieving option is really gaining a lot of traction and almost mainstream at this point. And we may have certain opinions about that. So we need to kind of think about all these things and then be respectful of what our patients choose. And as nurses, we can always educate, but you have to remain respectful, right? All right. So this is ethical dilemmas in professional practice still. So it takes moral courage for nurses to stay strong and resilient in the face of many forms of adversity in today's practice settings. Moral courage involves actions that stand up to wrongdoing. It requires the willingness to be honest in the face of personal risk. For many nurses, it is a fundamental part of their fabric and a key reason they sought out the profession. There is ample reason to celebrate the moral courage of nurses, for in many cases they go to extremes and expose themselves to personal harm in order to advocate for and protect the rights of their patients. Moral courage requires the practice of discernment. As nurses practice over time, they gain clinical and practical wisdom and the quality of discernment, which allows them to gather pertinent data in a given situation and create informed conclusions based on their accumulated practice-based wisdom. So the longer you're a nurse, the more you're going to learn, right? Although the role of bias and burnout, among other factors, must also be considered, experienced nurses know intuitively when they must speak up about certain conditions, behaviors, or situations that violate patient or professional ethical standards. This is just very true. Related to communication, nurses spend proportionately, there we go, more time with their patients than do other healthcare providers and have opportunities to connect and form trusting relationships with them. This is not to minimize the trusted relationship that many providers have with their patients. However, when patients receive difficult or complex information from their providers, questions evolve, often when the provider is no longer available, leaving the nurse to answer them. Nurses must learn to carefully navigate the line between what they can and cannot divulge to a patient based on both scope of practice and professional and organizational guidelines. So this is knowing what you are professionally allowed to say. We always have to remember that this is in a professional context. Like, we may get close with a patient, but that doesn't mean we're friends of the family, right? If we are acting as a nurse, we need to keep that professionalism in mind. This talks also about social media, right? So a tragic number of nurses, physicians, and students have seen a promising career go by the wayside due to the indiscriminate use of social media sites on which they have, often unwittingly, posted information that proved to be sensitive and or damaging to their patients and organizations. Some mistakenly think that by not mentioning the patient or organization's name, they are not violating anyone's confidentiality. This is not accurate. The best practice is for nurses to refrain from even the smallest mention of patient and workplace related events in their social media use. I can tell you, I know probably about a handful of people who have been fired due to social media posts. I would highly recommend never posting from your facility, ever. Just don't do it. Facilities now have administration that are specifically looking at social media posts and are looking for things that do not go along with the values, mission statement, etc. of the facility, that violate protocols, and you will get fired. So I highly, and I love TikTok, I love it, I love Facebook, I love all of it, but do not post from your facility. It is, you are walking a very delicate line. And then of course, always with social media stuff, there's HIPAA, right? Um, let's see. You know, something with HIPAA, you know, we talk about HIPAA and fundamentals, but as you guys get into the hospital situation, I just want to remind you that HIPAA does not allow you to look up charts of patients that you are not assigned to. So even if your mom is in that hospital, you have, you know, maybe you're the power of attorney for your mom, and she has said, you know, you can look at all my charts, that's fine. HIPAA does not allow you to do that in that capacity. Even if it's your chart, believe that or not. Maybe you were at Banner Desert 2 months ago and now you're at Banner Desert for your clinical rotation. You cannot look up your own chart in that capacity. Believe it or not, that is a violation of HIPAA. We did have this come up. The facility was not happy about it. So just keep in mind, just always be mindful of HIPAA. Okay, medical records are on a need to know basis. For students, that means that you have been assigned to that student, or to that patient, and that is your need to know. Also remember, we cannot copy things out of charts. You know, we can handwrite things, but we cannot copy things, and we don't use any identifying information. So just be mindful of HIPAA. It is a real thing, and you can get in trouble for HIPAA violations. So ethical dilemmas in professional practice, workplace incivility. So this is interesting. No other profession has as many approved levels of entry into practice, right? This means we are working with all different healthcare providers, you know, respiratory therapists, physicians, nurses, CNAs, physical therapy, right? All of these people. So this can include associate degree people, diploma, which is hospital based. We don't see that so much in Arizona, but if you were go to the East Coast, there's still diploma or hospital based nursing degrees. You can have a BSN. We have master's degree nurses, right? We have clinical nurse leaders, all leading to eligibility to seek the licensure to be a registered nurse. So basically all these people are nurses. If one also considers age, race, and gender biases by combining all of these nurses on a unit, under the pressure of understaffing or high acuity patients with good, bad, or uncertain leadership, it is easy to see a prescription for conflict. So basically what this is saying is that we work with a whole bunch of different types of people, a whole bunch of different type of nurses from different backgrounds, different degrees, different ages, different everything. And we all work on the same floor and we're supposed to get along, right? At least professionally. So workplace incivility may also extend beyond nurse-to-nurse relationships into other professional relationships, as well as nurse-patient relationships. There have been recent cases in which nurses have sued or pressed criminal charges against workplace colleagues of various professions, patients, or patient support persons. Violence, bullying, or incivility, regardless of the source, has detrimental effects on individual nurses, the nursing profession, and healthcare organizations. Nurses must focus on developing positive interpersonal relationships with all members of the healthcare team, advocate for support resources, and push for institutional policies that will reduce negative behaviors and the negative consequences that result for victims. So basically, we need to try to get along. But if there are cases of real bullying, real incivility, not just they didn't want to eat lunch with you, right? But real things, we need to take action because this makes for a work environment that nobody wants to be part of. And if we are not getting along, if there is incivility on the floor, that definitely affects patient care. And patients or families are going to pick up on that. And that is not okay. And it doesn't make a good environment for anybody, right? Now it comes down, now we're talking about ethics committees. So, and we kind of talked about this already, right? One of the primary roles for the nurse in a situation where there may be conflicting solutions is to recognize that there may be a question of ethics involved and to include the appropriate personnel. Ethics committees consist of healthcare providers from many different disciplines. Ethics committees are similar to an interprofessional team, but an ethics committee examines ethical dilemmas as they arise in an agency and creates policies to assist with decision making. Ethics committees may also provide guidelines for professional ethical problems, serve as a forum for open discussion of the problem, and act as a patient's advocate as needed. Ethics committees usually have one of three distinct structures, but can blend these structures as needed. So ethics committee is responsible for creating policies by which ethical decisions are made so that the rights of the patients are protected. The committee also describes the role of each member of the healthcare team and the patients and the families in making decisions. Consultations for ethical problems might be performed by a single consultant, a consultation team, or a full ethics committee, depending on the healthcare organization's preferred structure. Practicing nurses should utilize their organization's ethics consultation services whenever an interdisciplinary approach seems necessary for solving an ethics conflict. And like we talked about, as nurses, you can call for an ethics committee. So Chapter 6, Geriatric Implications for Med-Surg Nursing. So this is interesting. So presently, old age is defined by 3 stages, right? The age range of 65 to 75 is considered young old. The range of 75 to 85 is old. And from 85 upward is termed the old or oldest old, right? And if you've worked with older people, like, this to be true, right? There's definitely differences. Just saying somebody is old doesn't encompass everyone. So death in advanced years is not caused by old age, but by disease processes or infections. Senescence refers to normal age-related changes in the organ system. Individual humans age differently, but there are changes that affect all people in a similar manner. In general, there are several processes that affect all body systems. So these are expected changes, okay? So sclerosis is the hardening of tissue due to fibrous tissue overgrowth. Stenosis is the narrowing or constricting of a passage or orifice. Atrophy is defined as a wasting away or decrease in the size of an organ. Calcification occurs normally as part of bone formation. However, calcium and calcium salts can be deposited abnormally in other organs, including blood vessels. So our worry would be that this could obstruct something, right? On a functional level, there is a general tendency for slowing, shrinking, and stiffening. Yes. Gaits slow down, height is diminished, and range of motion decreases. Organ systems develop these changes in differing rates between individuals and within an individual. For example, mobility and strength in an 85-year-old man may be good while he suffers from cataracts, but markedly diminished hearing. His 85-year-old neighbor may need to use a walker, but has excellent vision and hearing, right? So variations exist. These processes do not necessarily bring on disease, but they create limitations in normal activities. Healthy aging entails compensation for these limitations by way of healthy lifestyle choices and interventions and factors that can be controlled. Heart and vascular disease. So this is page 71 of your F.A. Davis, all right? Heart and vascular disease, such as hypertension, coronary artery disease, and myocardial infarction, MI, occur as a result of sclerotic changes in blood vessels and heart wall muscle tissues, particularly coronary arteries. Systolic blood pressure rises because of the stiffening of systemic arteries. So as somebody is aging, we're kind of expecting their systolic to be a little harder or little higher, right? Because those arteries are stiffening as a natural aging process. So when blood flow is decreased to the heart muscle, death of the tissue or infarction occurs. Heart failure is most often caused by an MI or hypertension. Damaged heart muscle results in weakened contractility. The pumping function of the heart becomes impaired and fluid accumulation develops in the lungs and tissues. Because, right, the heart's a pump and it's not pumping as well. So that means we're not going to be able to pump as much fluid efficiently as when we were younger. So pulmonary edema, which is just fluid in the lungs, causes shortness of breath and the inability to breathe while lying flat, and can be life-threatening. Edema in dependent areas of the body, most often the feet and legs, can develop as well and is an early sign of heart failure. Because again, that fluid is not moving the way that it should, right? Gravity can be our friend or can work against us. And so with edema in the feet and legs, gravity is working against us. That is the lowest point of our body. And if our pump is not working well enough, then it is not pulling all of that fluid up and processing it through, okay? So we end up with dependent edema, all right? The prevalence of heart failure in those age 80 or older is 10%. This also talks about AFib. So atrial fibrillation is related to changes in the pacemaker cells in the atrium, contributing to the development of atrial fibrillation. And remember, fibrillation is just fibrillating, right? The pacemaker cells fire sporadically, resulting in a rapid twitching of the atria. This produces inefficient filling of the ventricles and a backup of blood in the atria. The main danger of AFib is the formation of blood clots in the right atrium, which puts the patient at risk for systemic embolization. So anytime we have an embolus of whatever sort, our worry is that it's going to go clog something. Stroke is the most common complication of AFib and the resultant embolization. So stroke related to obstruction. Heart disease continues to be the #1 cause of death in those over 65. Stroke is the 5th leading cause of death. Risk factors that can be modified to prevent heart disease and stroke include hypertension, high cholesterol levels, diabetes, smoking, obesity, poor diet, and physical inactivity. So those are all conversations that we would be having with patients, right? Is about those modifiable disease risk factors. All right, respiratory issues that can occur in the geriatric population. So this is page 72 of F.A. Davis. So pneumonia. Pneumonia, it can be bacterial, viral, related to aspiration. You can have bronchiolitis, which is, inflammation of the little bronchioles. So there's a decrease in the lungs' elastic recoil, and diminished compliance cause decreased alveolar expansion. So the alveolar are what, if you remember, they're the ones that are responsible for gas exchange, right? And they go in and out like a balloon, and they're responsible for gas exchange. So if the expansion, if the in and out is not working the way it's supposed to, obviously we're not going to have adequate gas exchange anymore, and that ends up with a whole other problem. There's also a weakened cough reflex and weaken diaphragm strength. So you end up with pooling of secretions in the lungs. Part of the cough reflex and having a strong diaphragm, we are able to move all those secretions that sit in the bottom of the lungs. But if we are not able to cough adequately and we don't have the strength to cough adequately, then all that stuff just sits there. So we have fluid in the bottom of the lungs. Bacteria is going to love that for growth, and that contributes to infections. Older adults can have impaired swallowing, so that's a risk for aspiration and pneumonia. We may want to use thickening agents in liquids because thicker fluids are easier to swallow, and that way that will reduce the risk of aspiration. Also, the book now, talks about COVID. So older adults are more likely to become severely ill with COVID. Just remember, the older you get, the less reserve you have. So the older you become, the harder it is to recover, right? We may also have unvaccinated adults who they claim are more likely to be hospitalized or die to the infection. Let's see. Obviously, those over the age of 85 are at the greatest risk, right? That's the old. And again, the older you are, the harder it is to recover, okay? This statistic says that over 75% of total COVID deaths in the US were people over the age of 65. So obviously geriatrics plays a role in that. COPD and asthma, right? COPD talks about emphysema and chronic bronchitis. Smoking, primary risk related to COPD, period, hands down. Those age 65 and over have the highest rate of chronic bronchitis, and then asthma affects 4 to 13% of the over 65 population. So that can compound COPD, right? With COPD, we have problems with gas exchange. So the body ends up retaining CO2 and not retaining enough oxygen. There's not enough oxygen exchange. So that leads to obviously problems of breathing, but it wear and tear on all the other organs because the other organs, including the brain, like to have adequate oxygen, right? So if we don't have enough oxygen anywhere, we have systemic wear and tear, period. Nothing's functioning the way it should. And we talk about COPD and asthma a lot more in depth in our respiratory module. Also, dementia comes into play with older adults. Dementia is defined as a progressive cognitive decline that affects a person's social and occupational functioning. Loss of the ability to think, reason, and remember interferes with communicating and relating to others. In addition, dementia prevents accomplishing instrumental activities of daily living, such as paying bills, making appointments, shopping, and maintaining a household. It can become severe enough to affect the individual's ability to perform ADLs, such as dressing, bathing, eating, and walking, right? So with dementia, you may not be able to function the way that you used to be able to function. Delirium, as opposed to dementia, is an acute onset and reversible syndrome that is especially common in older adult population. Delirium may manifest with hypoactive or hyperactive symptoms and can shift within one individual over the course of hours to days. Inattention, inability to focus, drowsiness, confusion, and agitation, hallucinations, and other cognitive changes are all characteristic findings in delirium. It is a frequently occurring condition that in the early stages can go unnoticed by healthcare providers and even family members. More severe cases of delirium have been associated with increased mortality rates, hospitalizations, and negative outcomes in older adults. Increasing age, frailty, and underlying dementia are some risk factors contributing to likelihood of developing delirium, especially when acute illness is also a factor. So a lot of times when older people are in facilities, they will experience some level of delirium. Delirium is usually assessed at least once per shift, and then if you see any sort of cognitive change, you reassess, you do a delirium assessment. Um, people are in unfamiliar surroundings. Maybe, normally they have their spouse with them daily or pets with them daily, and all of that has changed. And delirium can come on quickly. It's really interesting. Depression can also happen, right? And know that depression is not a normal part of aging, but it is a common problem and it needs to be treated because we want our old people having the best life, right? So, National Institutes of Health has reported that depression in people aged 65 and older is a major public health problem. The suicide rate of people 80 to 84 years of age is twice that of general populations. Isn't that crazy? Some symptoms of depression are similar to naturally occurring changes of aging and make diagnosis more challenging. For instance, lower energy levels, difficulty sleeping, less appetite, aches and pains, and difficulty remembering details are some of the symptoms shared by depression and the aging body. So the symptoms of a major depressive episode are the same regardless of age, though, all right? People may have sleep pattern disruptions. So older adults with Alzheimer's and other types of dementia may have increased sleep pattern disruptions that can further alter their neurological state. There are multiple sleep hygiene methods that can help encourage a healthy sleeping routine. Exercise and limiting daytime naps, limiting caffeine intake, especially later in the day, and creating a calming bedtime routine can all help encourage healthy sleeping. Also, limiting fluid intake later in the day can help prevent frequent nighttime awakenings that will disrupt the sleep pattern. Parkinson's disease. So Parkinson's is considered a type of dementia. It's a degenerative condition that primarily affects movement. It causes tremors, rigidity, and gait disturbances, and can also adversely affect speech. Cerebrovascular accidents, so CVA or stroke, is primarily a vascular disease with neurological consequences. Paralysis, weakness in speech, and vision impairments can range from minor to devastating. If treated immediately, neurological damage can be minimized or prevented. This is the table in your book that just differentiates between different dementia versus delirium. Okay, so just take a little bit, just look at that a little bit, because there is a difference. Age-related GU and reproductive changes. Those are noted on table 6.7. So changes include a general decline in bladder function and capacity. Capacity actually can shrink by up to 50%. Isn't that crazy? Uterine and vaginal atrophy, and decreased reproductive hormone levels. So your hormone levels, hormones, dictate everything, right? And all your hormones go away, so nothing works right. Super fun. GI changes. Typical changes include slowed gastric emptying, delayed transport through the colon, increases in acid secretion, and a decrease in the organ size of the liver and pancreas. So this is why people, they just tend to be not that hungry. And maybe they poop every other day versus every day. Maybe they get heartburn more frequently, related to that increased acid secretion. So common health issues can include increased risk of gastric and duodenal ulcers and atrophic gastritis. That's related to that increased acid. GERD, also increased acid. B12 deficiency and maybe some anemia. Increased fullness after a meal because of that decrease in emptying. You can also end up with nutritional deficiencies because maybe they're not eating as much, right? They can have bone loss. This can result in osteoporosis, which we talk about later. They can have constipation and fecal impaction. Um, as the bowel slows down, you can end up with obstructions. So, and older people tend to be dehydrated, so they're not having all the fluid, that helps poop be nice and soft and, easier to get out. Plus, meds can have constipating effects. So, taking all of that into consideration, constipation is certainly something we want our older people to be on top of, right? But they're not going to be having all the signs and symptoms that we may have as younger people to identify that as a risk. There's risk for adverse reactions and toxicity from medication because of liver changes. The liver is basically a filter, and if it is not filtering and getting all those toxins out the way that it should, you can have buildup of things that you normally wouldn't in a younger person. Type 2 diabetes is a big problem in older adults. A lot of times it can go undiagnosed, and then by the time they're having signs and symptoms that they notice, bigger problems have set in. So there's a lot of considerations with the older population. As part of the aging process, sense and smell diminish, making food less appetizing. So, that's another reason they may not eat as much, because it just doesn't smell as good, right? Doesn't taste as good, doesn't smell as good. Um, they can have changes in fullness leading to constipation, which we just talked about. They may have problems chewing, right? Maybe their teeth aren't so great. Maybe they have dentures that don't fit well. Maybe they don't have dentures at all but need them, right? So all of that can be a problem. Difficulty swallowing, dehydration. Let's see, a lot of times people, if they're having trouble swallowing, they pocket food, which means they kind of like stick it in their cheeks or under their tongue. They can do this with medications also. This leads to risk of aspiration. We talked about side effects from medications. Social isolation. Eating is a very social thing in our culture, right? And lots of cultures, very social. If they have social isolation, they may just not even think about eating. There's no joy in it, basically. If they have any dementias, they may not remember to eat, okay, right? They may go to the kitchen and get sidetracked. They're certainly not going to remember to drink all their water. So when we are working with older people, we need to do a comprehensive nutritional assessment. We need to see what's happening. Failure to thrive is something that we see in older adults, and this is a condition of unintended weight loss. So they actually use failure to thrive in pediatrics a lot, right? That's probably where we hear about it the most. But it also applies to our older generation. It is defined as a weight loss of greater than 5%, decreased appetite, poor nutrition, physical inactivity, and low cholesterol, and depression. So it's multidimensional with 4 chief characteristics. So impaired physical functioning, malnutrition, depression, and cognitive impairment. And there are multiple medical conditions as well as medications that are associated with failure to thrive in older patients. However, 25% of the population that this is identified in, there's actually no other identifiable medical cause. Be aware, so cachexia is the weight of loss of weight and muscle mass, and it cannot be reversed nutritionally. We also talk about cachexia related to AIDS patients. It is not just that they are skinny, they literally look like skeletons. And this is because we've not just lost fat, but you've lost muscle and you're not getting it back. So this is not a good thing. If not treated, it can lead to rapid physical decline. And cachexia has a very poor prognosis because this is, our muscles and our fat I mean, muscles obviously keep everything functioning, and fat is a reserve. And when we have no reserve, we're in big trouble. Age-related musculoskeletal changes. This is table 6.9 in your book. You're going to have decrease in muscle mass, stiffening of tendons and ligaments, decreased bone density, and increased bone loss. And that is called osteoporosis. These are fall considerations, right? If we have all these muscle and bone changes, all this weakness going on, obviously fall considerations are a thing. Fall preventions are the 4 Ps, right? So that is pain. This is for in the hospital. Pain, pottying, positioning, and possessions. So what this means is we want to be, as nurses, on top of these 4 things. We want to make sure our person's not in pain. That can cause restlessness. Maybe they're rolling around. Maybe they roll around and scoot themselves right out of the bed, right? Pottying. One of the biggest reasons people try to get out of bed and fall is because they have to go to the bathroom. And this is even with people with a Foley. And you will explain, sir, you have a Foley in, it's draining your bladder, you know, you're good to go. But they will try to get out of bed and they will fall. So this is something we just have to be mindful of. You know, there's stuff like a bedside commode, you know, which is a toilet that can go next to the bed. So the person does not have to walk across the room to get to the toilet. You know, there's things that we can do. Positioning, making sure people are comfortable. Because again, if they start rolling and moving, they may roll right out of that bed. And then possessions. When we leave a room, we want to make sure they have their bedside table. We want to make sure they have their phone, their charger, their book, their remote, the call light, the water, the snacks, right? All the things. So that they don't feel compelled to get out of bed and go get those things. A lot of times with older people, they'll say to you, well, I didn't want to bother you. I just thought I could get up and go get it. You know, they don't want to be a nuisance. Some of them do, but a lot of them don't. They don't want to be a nuisance. So if we can make sure we have everything taken care of before we leave the room, that's our best bet in preventing falls. There are age-related immunological and skin changes. These are noted on table 6.10. So there's a general diminishing of immune function, right? The skin's ability to function as a barrier is also diminished. You know, and keep in mind the skin is our number 1 thing keeping us safe from infection. And now as an older person, you have skin that rips easier, tears easier. And now we have, you know, open invitation to bacteria and whatnot to get in and cause a problem. So common immunological and skin-related health issues include the following. So blunted response to infection. So the body doesn't respond to infection the way that it used to. Older people may not have a fever. White blood cells may not be elevated. They may not have the normal vital signs, like blood pressure may not go up. Usually signs and symptoms of infection that present with older people are behavioral. When grandma wants to fight you, she probably has a UTI. This is just a thing. They may not have pain. They may not note the pain, but they may have mood shifts, memory loss, inattention, confusion, and lethargy. So it's really interesting. It definitely presents as behavior. They may not want to eat. They may be aggravated when maybe they were like super sweet the day before, right? So changes in the skin can also lead to pressure injuries, shingles. You know, don't forget shingles are related to the chickenpox disease. They hang out in the CNS. And then when you have periods of stress or your body is depleted because of other illness, shingles decides to rear its ugly head and erupt, right? It's considered opportunistic because it needs your body to be somehow depleted, whether it's related to stress or disease process. Shingles needs your body to be somehow depleted for it to come forth, right? And then you've got a shingles infection. Intrinsic factors that are related for skin health are related to like cellular processes and stuff. Extrinsic aging, like environmental concerns, smoking, UV, medications, chronic illness, all of that plays into how well the skin regenerates, and if you have a wound, how well that wound heals. So sensory changes. So decrease in visual acuity and hearing are common. Prevalence of hearing loss doubles with every decade. Okay, that's crazy. Hearing loss occurs with age, is usually caused by the intrinsic aging of the auditory system. It rarely develops into total deafness. It can most often be managed with a hearing aid. Hearing problems can contribute to miscommunication. Conversations and comments directed to the individual can be misinterpreted. Older adults may begin to avoid social contacts because they cannot really hear what others are saying. When healthcare providers are conducting assessments and interviews, incomplete or erroneous information may be collected as a result of the older adult not understanding what is being asked. Lower tones of voice are heard better than high-pitched tones. This is important to know because we may be asking questions and the person may just be agreeing with us because they cannot actually understand what is being said. So then we have safety issues, right? Care priorities can be broadly discussed as safety and psychosocial issues. Safety considerations are a priority and have been discussed throughout this chapter in relation to the physical changes that naturally occur with aging. They include physical safety and medication safety. Another safety concern is the potential for abuse and being protected from possible abusive situations involving strangers and caregivers alike. Complicating the maintenance of safety for older adults is the fact that they often do not perceive that they are in danger, right? They may have a family member caring for them. Are you going to suspect a family member of being abusive? I'm sure in fundamentals you talked about the fact that this could be like financial abuse. Maybe a family member has, is on the patient's checking account and whatnot, and they're just spending through the person's Social Security. Meanwhile, the person thinks that their person is guarding and taking care of them when in reality they're not. This can apply to food. This can apply to taking somebody to doctor's appointments. Maybe somebody decided that the insulin was too expensive and they're not picking up the insulin for the person. Who knows how this can happen. So also there's physical safety. So natural occurring changes in strength, flexibility, balance, and reflex time combine to put older adults at risk for accidents and falls. If the home environment is not upgraded to compensate for the frailties of age, there can be risks of falling in the bathtub or shower, tripping over rugs and electrical cords, and falling from step ladders and makeshift climbing devices. There is less room for compensation and less margin for safety when a fall does occur. Basically, like we talked about, they just don't heal the same. There is greater chance of serious injury, such as fracture, hemorrhage, or loss of consciousness. Another important safety issue is driving. Older adult drivers are at risk and put others at risk. Decreased speed of reflex response and decision making, as well as visual and hearing problems, can prevent awareness of dangerous traffic situations. Early unrecognized dementia can impair an older adult's ability to follow traffic lights, directions, and other driver's signals. I mean, think about driving on the 60, where like the average speed is 85, right? Can you imagine having an older person who maybe has some dementia, their reflexes aren't what they used to be, a tire has a blowout? Is that older person going to be able to respond as quickly and appropriately as somebody who's younger? No, definitely not. You know, it's a risk. So we always want to think about having unfortunately difficult conversations with probably family members related to making sure that they have taken away the keys from older individuals, right? And that I can tell you from personal experience, that's never a fun conversation. In the hospital setting, older adult patients have safety issues due to the development of behavioral problems as a result of the illness for which they are hospitalized. Sudden severe illness, dehydration, infections, and dementia can result in delirium. Patients with delirium suffer from confusion, disorientation, and altered level of consciousness, and sometimes have aggressive behavior. In the past, the use of restraints was common in these circumstances to keep older adults safe, but it is now recognized that the current standard of practice is the avoidance of either physical or chemical, meaning medicating with sedatives or antipsychotic restraints. The present approach combines investigating possible causes of the behavior, addressing unmet needs and physiological conditions, reducing fall risk by modifying the environment, and providing close continual observation and assistance. Included in the approach is the use of the least invasive treatments. So I can tell you, you know, we used to use, basically you can use restraints when somebody is a risk to themselves because they are going to pull at, we term it life-saving tubes and lines. So this may be like the Foley, the trach, the ventilator tubing, maybe even a central line, right? So life-saving tubes and lines. If somebody is going to pull at those life-saving tubes and lines, you are justified in using restraints. Now we can use mitts. They actually are like a boxing glove. They're very soft, they're cotton, they have padding on them. I can tell you from personal experience, they do not hurt when you are punched with a mitt, right? So don't be afraid, it's okay, get on in there. And also, when this talks about modifying the environment, like you can get beds that sit lower to the ground, right? So, you know, keeping a bed in the lowest position, side rails ×2, maybe no side rails because we're worried about the person trying to climb over the side rail. I have also absolutely parked my nursing wow right outside somebody's door, right? And so I can't be there the whole 12 hours, but when I'm charting or when I have a moment, I'm right outside their door. A lot of times we'll have a sitter on somebody, but sometimes staffing does not allow for a sitter. So you have to make accommodations where you can. Maybe bringing somebody to the nursing station in a wheelchair if that's appropriate. Getting them out of their room where you can have more eyeballs on this person. We definitely try not to use wrist restraints on older people. It can cause skin damage. It's angering to people, which certainly does not help with the behavior aspect of things. So the least invasive is always what we want to go to. And you want to try as many things as you can, right? Older persons are at risk of injury from their own medication. A person over the age of 65 takes up to six, or not up to, but on average, 6 prescription medications. 6, right? The individual may also take over-the-counter meds. Each med has its own side effects, and the combination of drugs increases the chances for adverse or deleterious effects. So it can affect their level of consciousness. Older adults often need education, guidance, and support in order to follow the medication regimens that their primary providers are prescribing. Some of the normal aging changes in visual acuity, memory, and strength can interfere with correct and successful medication management. Problems such as being able to read the prescription label, remembering to take the medication at the right time and the right number of times a day, being able to open the pill bottle or container, and being able to go to the drugstore for refills if the pharmacy does not deliver are all factors that increase the risk of errors in medication management. Polypharmacy has been identified as a major problem for older adults. Polypharmacy is generally defined as being prescribed 6 or more medications and or using a potentially inappropriate medication. Tools containing criteria for medication evaluation are readily available for the nurse to use. One of the most commonly used tools is the Beers criteria for potentially inappropriate medication use in older adults. So this is just looking at dosing, duplicate medications, things that can interact with each other, um, making sure that this is, it's a med rec, right? Med reconciliation, and that's what we're doing. And when a person gets discharged, we want to make sure that we are going over this with the patient and hopefully whoever is going to be the caregiver, right? Because you always want to have backup information, somebody else who's trained. You want to have written materials. I even write my dog was on pills, and I write in Sharpie on the container what the med is and when to take it, because it's I need reading glasses, so it's annoying to have to find reading glasses, try to read the small print, need appropriate light, blah blah blah. So something as simple as just writing with a Sharpie on the pill bottle can help. Also, pharmacies offer easy open pill containers that are an option for older adults. So we need to make sure our geriatric population is aware of things like that can help them. Writing out a schedule that they put on their cabinet, right? Using pill containers, the weekly pill container things, all of that stuff can be helpful. This is the Beers criteria for you to look at. So this just talks about different medications that can interact or affect older adults negatively. So take a look at this slide. This is slide 57. This talks about elder abuse, right? So potential vulnerability of older adults due to increased physical weakness and possible cognitive impairment, as well as the stress that they may place on caregivers, makes them unintended and intended targets for abuse, right? So it can be unintentional or intentional. They may suffer physical and emotional abuse at the hands of caregivers. This can be neglect or abandonment, and it may be related to a caregiver becoming overly stressed. Also, older adults can become victims of scams and financial exploitation by strangers, right? We see this in people being catfished, right? And it can also be in the form of somebody calls and says, they're your bank and there's a problem and you need to give me your information so I can verify. And older people, not really knowing these types of scams are out there, maybe hand over all their information, right? So the National Council on Aging says that 1 in 10 Americans over age 60 has been subject to some form of elder abuse. And that's just crazy. So as nurses, when we are working with families and patients, whether we're admitting, discharging, or just in general interaction, we need to be kind of paying attention. Because especially if we're discharging home with a family member as a caregiver, is this an appropriate and safe opportunity or alternative for our person to go home to, right? And then we need to let somebody know about that. This is the CDC definition of elder abuse. So just take a look at that. It talks about physical abuse, sexual abuse, emotional or psychosocial, talks about neglect, and then financial abuse, right? Which we talked about a little bit earlier. So again, as nurses, you want to be aware of these because you want to be paying attention to what may be going on with your patient. This talks about just the psychosocial aspect of becoming older, right? Becoming old is not a biological process, is not only a biological process, but also a social and cultural one. As people age, their roles and status in life change, and they acquire another social identity. Older adults are often neglected, dismissed, or ignored. They can experience a form of discrimination termed ageism, where they are treated with less respect and consideration because of their advanced age. One of the tasks this group faces is how to accept a different and more dependent role after an adult lifetime of independence, right? Imagine you did all the things for yourself. You've been an adult for a long time, you live on your own, you take care of all your things, and all of a sudden you can't, right? You need help again, okay? Maybe you're not working anymore, you're retired, friends are dying, family, brothers, sisters dying, it's huge. Your kids have moved on in life. Your kids are going to be old enough that they're busy in careers. Maybe you have grandkids, but they're in school. So there's a lot of changes. Then of course we throw in the vision, hearing, and mobility impairments. We talked about not being able to drive anymore. Especially living in some place like Phoenix, yeah, we have public transportation, but it's not amazing, right? So, definitely independence gets affected. You have financial aspects, alteration in self-image. Anybody, as you get older, there's changes, right? There's changes. This also talks about sexual identity and sexual activity. That can be related to hormones, that can be related to straight up physical aspects. You just can't bend the way you used to, right? So there's all these things to consider. Erikson is kind of who we think of philosophy-wise related to developmental stages in life. And so his last one is late adulthood, and this is 60 to death, right? So, and a lot of times people may be looking back on their life. You can have accomplishment, but you may have regret as well. So they're going through a lot of psychosocial changes. I don't know how many of you work in healthcare, but you'll go in to ask a simple question like, when was your last bowel movement? And you're in a 40-minute conversation about something that happened in 1962, right? There can be isolation. And so, when they have opportunity to chit chat, they take it. And as the nurse, that definitely comes, we are the person that they like to chit chat to a lot. So just be aware of that. We also, at another point in, I don't know if it's this PowerPoint or a different module, but it talks about, making sure that you set aside some time to talk with your older patients. Go in, sit in the chair, make eye contact, take a more casual approach to if you are talking to them, whether it's working on getting a medical history or, whatever the case may be, but taking the time and just knowing that you're going to have to take the time, right? Because the conversation's going to go better. This talks about advanced directives and living will. So we kind of talked about those earlier. Advanced directives talk about like what life-saving procedures they want or don't want. It may identify a member to make healthcare decisions for them. A living will can also talk about healthcare choices and treatment that are acceptable or not acceptable. So when a patient admits to a facility, the facility will usually request copies of these. What this comes into play for us as floor nurses in particular, we want to know their whether they're DNR, full code, their code response. And then we want to know who the decision maker is, who is legally allowed to have medical information about this person. Because one of the things we identified during COVID was you'd have 87 family members calling to get updates because people could not visit. Well, legally, because of HIPAA, you cannot disclose medical information to just anybody. So if somebody has a document identifying a person that legally can have their healthcare information, then now we have one person who we can give information to, and then we specify that it is that person's position then to disseminate that information to other family members as they see fit. That saves us from having to take 87 phone calls from family members and repeat ourselves throughout our day. Because every time we're on the phone, we're being taken away from patient care, right? And also visitors. You know, I might spend 10 minutes with the daughter who is the medical power of attorney, but I don't want to have to repeat that story every time somebody comes to visit. So it's very helpful to know who is the designated person and then put that person in charge of getting information out there. Okay. And so when somebody else comes in and says, hey, what's going on? We can say, you know what? You need to talk to the patient's daughter about that. She has been briefed. She has all the information. She is legally empowered to disseminate that information. This talks about palliative and hospice care. So palliative is provided to individuals with severe illness, and the goal is to increase quality of life while they are undergoing treatment. Hospice care is about symptom management and comfort for severely ill who are approaching end of life. So both palliative and hospice have an underlying goal of comfort and symptom management. But under hospice care, curative treatment of the underlying illness is stopped. So if our person is a cancer person, you know, we're not doing chemo, we're not doing radiation, we've stopped that, okay? We are just providing comfort until end of life. Now under palliative, you may still have treatments going on, and we're just trying to make sure that your day-to-day is as good as it can be, right? A lot of times, facilities now will have palliative and hospice care physicians where you can order a consult to come in and talk to the families. Recently, you know, my dad just passed away in September, and we ended up going into hospice care with him. And it's interesting because hospice care affects your insurance differently. And so there's a whole different way that things are paid for. And it's much easier to take someone home on hospice because a lot of things are covered under hospice care that are not covered under general care. So there's a lot of considerations that go into hospice care. There's not a time limit on hospice or palliative. If you go beyond 6 months, they just re-up care, and that just takes a physician assessment. So it's not a time constraint. It's not anything like that. So it's actually a very good option for families when they are trying to decide how they want to care for their person. A lot of times people will say, I don't want my family member in a facility. I don't want them in a SNF. You know, what are my options? Palliative and hospice care can often provide those options to make in-home care a viable decision. So, you know, you may relay onto a physician as a nurse, hey, palliative or hospice consult might be appropriate for this family. And then palliative and hospice just comes and talks to the family. And then that's that decision from there. So that's one of those things that as floor nurses, we just want to be aware of. All right, we're moving on to overview of cancer care. This is chapter 13. All right, so globally, cancer is the leading cause of death in every country of the world and rising in incidence. Most common types of cancer are lung, breast, colorectal, prostate, skin, and stomach. However, cancer incidence, so that's the rate of new cases, prevalence, which is the number of total cases, and mortality vary on the basis of sex, gender, national socioeconomic indicators, and carcinogen exposure. So when I think of carcinogen exposure, you know, think of like, first of all, what's in the air around us? And then where do we work? Do we work in industry? Do we work in a plant that continuously has carcinogens floating in the air? Are we smokers? You know, what are we exposing ourselves to related to carcinogens? So in the US, the statistic on the US is that cancer is the second most common illness and cause of death. So kind of scary. This is the pathophysiology. So cancer is a constellation of diseases involving a malignant, so unregulated transformation of cells within a specific body system. Although there are many different types of cancers, all cancers are characterized by uncontrolled growth of malignant cells that compromises the integrity and function of normal healthy cells. Cancer affects people of all ages, infants to adults. Its clinical presentation can vary from severe and acute clinical findings to a more chronic and indolent or slowly developing disease. Clinical features vary on the basis of cancer type, staging, and specific molecular characteristics. Cancer initiation typically begins with carcinogen exposure, which subsequently triggers single or multiple gene mutations. An individual likely experiences multiple carcinogen exposures and genetic mutations over time. However, the immune system protects the individual by recognizing the mutation and initiating cell death. So our immune system is set up to take over these mutated cells, to kill them, right? But what happens is when the immune system can't keep up with the rate of growth of these mutated cells, okay? So in carcinogenesis, so the birth of these carcinogenic cells, the mutated cells are not detected by the immune system and are therefore able to proliferate and progress into cancer. The specific gene or multiple gene associations with different types of cancer is a growing field of study, and many cancers have identified mutations that can be abrogated with newer targeted anti-neoplastic therapies. So cancer characteristics, cancer is characterized by two hallmark characteristics. So uncontrolled cell growth, they are just proliferating like crazy, and altered cell differentiation. So they are not, they're mutated, right? They're not the cells the way that they're supposed to be. Metastasis, so cancer cells replicate and expand locally into masses of cells known as malignant tumors. The propensity for tumors to spread is called metastasis. Cancer cells spread by cell-to-cell transfer through the lymphatic system or through the blood. Cell-to-cell transfer is characterized by direct invasion into adjacent cells, so cells that are like near each other, right? Lymphatic spread occurs when the tumor cells migrate into the lymphatic system, using lymph channels that serve the organ where the cancer originated. Once in a lymph node, the cancer cell may be destroyed, grow into a mass, remain dormant, or spread to more distant lymph nodes, and potentially into the vasculature. Hematological spread, or spread through the blood system, typically occurs when the cancer cell migrates into the venous system that drains the organ where the cancer originated. So that is how cancer ends up spreading through the body, right? It's in one located area, it gets into the lymph system, it travels through the vascular system to another lymph node, it becomes systemic, and then we're in real trouble. So cancer types. Cancers are generally divided into two main categories. We have solid tumors and hematological malignancies, so that would be blood, right? Solid tumor malignancies arise from specific body organs and grow into masses that invade and erode normal body tissue as they expand in size. An example of a solid tumor malignancy is lung cancer. Hematological malignancies arise from cells of the hematopoietic, I know I'm saying it wrong, it's fine, cell line, or from secondary immune organs such as the lymph node or the spleen. Cancers are further classified according to the organ of origin, sorry, my nose is running, or system of origin. The classification generally determines naming conventions, particularly for solid tumor malignancies. To illustrate, a malignant tumor arising from tissue in the lung is called lung cancer. Tissue types may also be included in the name. For example, cancers may arise from epithelial cells and are called carcinomas. So you can have like breast carcinoma. They may arise from squamous cells and are called squamous cell cancer, head and neck squamous cell cancer, right? So there we go. That is All right. So this is about staging. Once a cancer type has been diagnosed, the cancer is then further classified by stage. Staging is a classification system that considers the size of the tumor, burden of the disease, and extent of disease spread. The stage of disease is used to plan patient assessment, clinical management, and treatment strategies. So you can go through, look at the stages here, just be kind of familiar. Um, stage 4, sorry, is cancer with mets, meaning it has spread, okay? Stage 1 is localized. This is the clinical presentation of cancer. So we use the caution symptoms, right? You guys talked about that in fundamentals. Um, we use, let's see. So caution is just a warning sign for cancer. This is box 13.1 in your book. This is often when we have changes in those signs, that is often what causes somebody to go seek a medical provider, right? Because they notice the size and color, something like that. So cancer can also have signs and symptoms like fatigue, weight loss, fever, night sweats, not related to anything going on with the person. Some people can have characteristics of specific malignancy, so like clinical presentation. Those are related to the location of the primary cancer and the pathology of the disease. Here is a slide with our caution warning signs. So, changes in bowel or bladder, sore throat that doesn't heal, unusual bleeding or discharge, thickening of a lump, indigestion or difficulty swallowing, obvious change in a wart or mole, or nagging cough or hoarseness. And by nagging, what we mean is greater than 2 weeks. So primary prevention. Sorry, I've slipped through that slide really quick, but primary prevention is what we can do to prevent, what are our risk factors? Stuff of that like smoking, eating a healthy diet, staying away from carcinogens, all of that sort of stuff. Then we get into diagnosing. So like we said, a person usually goes to the doctor when they identify one of those caution signs or symptoms. There are diagnostic tests used to specifically diagnose specific cancer cells. Let's see, they can do molecular marking. So there's different markers that indicate different types of tumors. So they can look at the markers related to that. Then they stage the disease, which we talked about. Diagnostics. So that kind of depends on where the tumor is located, where the cancer cells are located. So there's lab tests, there's radiological tests, ultrasound, and they may use one or more of these tests when diagnosing and confirming cancer cells. And of course, also a biopsy, which can identify specific pathology. So all of that is possible. So nursing implications. So a cancer diagnosis for people, obviously stressful. So we're going to have to think emotional support, psychosocial considerations, being very supportive, making sure they have a support system, maybe connecting them with community support systems if they don't have people at home, whatever the case may be, but psychosocial really plays into this. Affirmation and clarification. We need to make sure that they understand, like for real, all the things that the doctor has told them. What treatment's going to be, what type of cancer we're talking about, what this progress looks like, what are the options, right? We talked about earlier that patients have the right to pick and choose what what type of treatment they want. So what are their options and what are the consequences of those options? All the things, we are really going to be there to offer support to this patient through this cancer diagnosis. Cancer nurses are another, like hospice nurses, special kind of nurse, right? They've been trained, it's different conversations. They're really adept at those hard conversations with people. Same with cancer nurses. They get used to having these hard conversations. I would be nowhere as good at this type of a conversation as a cancer nurse, as an oncology nurse, right? It is for sure a specialty, and a lot of that is not only the medications that you end up having to administer, but the difficult conversations you have to have. Therapeutic communication, we talk about it all the time, but it is a skill, and you become better with it with practice, and you can specialize with it for sure. And these types of nursing specialties require that to be a really mastered skill. Treatment of cancer varies on the type of cancer, stage of the disease, the markers. They use markers to identify, cell markers to identify what kind of treatments are going to be most effective. I would say most commonly we hear this related to breast cancer these days. What kind of markers? Her positive, her negative, all of that. Those are cell markers that direct care. So there's all sorts of things to go into consideration. And sometimes with cancer, you end up talking hospice or palliative care, right? Because maybe, cancer, unfortunately, if it has metastasized, gone systemic, it may be terminal. Some cancers are really nasty. And so hospice care may be a conversation. So there's all of that to think about. In a related note, remission is possible with cancers. Usually they go, I think it's 2 to 5 years without treatment can be how they measure remission. That means that the malignancy is not present, is not growing, is undetectable. And so, you can be in remission, which is possible, which is always probably the goal, right? Treatment modalities. So basically, it can be surgical, right? Removing the cancer itself, radiation, medical treatments, and cellular therapies. So that's basically the 4 areas that our treatments fall into: surgical, radiation, medical, or cellular. And those are dictated by the type of cancer, location of cancer, stage of cancer, all of that, and what the patient wants, right? Would it be could you see an 80-year-old person diagnosed with lung cancer deciding not to go through chemo? Because chemo is not an easy road, right? So, and does that patient have the right to make that decision? Yep, they totally do. So, a lot of considerations here. This was a giant PowerPoint, giant lecture. Thanks for hanging out. Anything you have questions about, please feel free to bring up with your instructors in class. And anything else you would like further information, feel free to email your instructors in Canvas, because we would always be happy to talk about that further. So thank you.